Hi, everyone. Thank you for joining us for the Peer Assessment Information webinar. This webinar is for people that have been selected for a peer assessment. If you were selected for evidence review, there's a different webinar for you to watch. My name is Dana Prucci. I am the Director of Professional Practice and Quality Assurance at CASLPO, and I've been here in this role for almost 5 years. Before that, I've worked as a speech-language pathologist in the pediatric world, both in the public and in the private. I do enjoy talking to people, even if it's about peer assessments. And we understand that these can be quite anxiety-provoking, but almost all the registrants who have gone through peer assessments have said that it was a valuable and positive experience. Our goal today is to help give you lots of information to get you through. And with me today is Caitlin Reed.
Hello, everybody. Thank you for joining us today. I am Caitlin. I'm the SLP Advisor in Professional Practice and Quality Assurance at CASLPO. I've been with CASLPO since May 2023, but before that, my clinical experience is with adults with acquired communication disorders and dysphagia in rehabilitation hospitals. Like Dana, I speak to registrants all the time in practice advice, and we're here to support you. There'll be lots of time to ask questions today, but if you think of something after the webinar, you can always reach out to us. So before we get into the content of the presentation, just a couple minor housekeeping items for using GoToWebinar. It's best to close other running applications to help maintain a stable connection to the platform. If you experience any technical issues, you can exit GoToWebinar and return into the session at any time today. This session is being recorded, and we'll post the video to CASLPO's website on the peer assessment page within the next couple of weeks. All participants are muted today, but you can ask questions by typing in the question box. On minor requests, it's easier for us to view if you include your whole question in the body of one message. How we see them is they come in like rows of a spreadsheet, and they get mixed in amongst other people's questions, and we lose the thread of what you've asked. We will have breaks for questions throughout the presentation, but you can submit questions at any time. We'll try our best to answer everything today. If you submit a question and we don't get to it, and it isn't answered in the content of the webinar, again, please feel free to email us afterwards. You can email either Dana, myself, or the general quality assurance inbox, and we'll make sure that we answer you. In the question periods today, we will try and pick more general questions that will help everybody, and the response will apply broadly. If it's something specific to your individual situation, it's better to email Dana directly than to pose your question here.
So let's go over the 3 topics that will help you through the process that we'll talk about today. First, we'll talk about the intention behind peer assessments and why CASLPO does them. Then we'll help you understand the process so you can meet deadlines and use your self-assessment tool as indicated for uploading evidence and using comments for your benefit. Lastly, we'll make sure you know where and how to access the resources that are available to support you. Starting with this webinar is a really great idea.
So we'll start with a refresher on CASLPO's role as the regulator of audiologists and speech-language pathologists in Ontario, what that means, and how peer assessments fit into this. So the why of peer assessments. CASLPO's mandate, which is set out in the Regulated Health Professions Act, which is a provincial law in Ontario, is to regulate individual audiologists and speech-language pathologists in the public interest. Regulation is done through 4 main functions. First, by confirming that entry to practice criteria have been met through registration. Second, by developing the minimum standards of practice that patients can expect to receive from the professions. Third, by ensuring that registrants maintain their competence through annual participation in the quality assurance program. And fourth, by responding to concerns and investigating complaints about individual audiologists and speech-language pathologists to uphold the public trust. These are what we term the 4 corners of regulation, and you should think about this from the patient's perspective. So for example, when we ourselves have been patients seeing a healthcare professional, like your family doctor, for example, We all expect that someone has verified that that person is qualified to practice, that's registration, that they continue to learn and grow professionally throughout their careers, that's quality assurance, that we can at least expect a minimum level of care from them, that's the professional practice standards, and that there's a mechanism to address if their practice has fallen below this minimum level, and that's professional conduct. All CASLPO registrants who hold either a general or an academic certificate of registration are required to participate in CASLPO's quality assurance program. Quality assurance is a fundamental component of health regulation to protect the public interest by ensuring that healthcare professionals are meeting minimum standards in their practice, engaging in continuous learning and staying current throughout their careers, and are providing safe, quality, ethical care to patients. All health regulatory colleges in Ontario, governed under the Regulated Health Professions Act, or RHPA, are mandated to have a quality assurance program that includes requirements for continuing education, self-assessment, peer and/or practice assessment, and monitoring of registrant participation. For registrants of CASLPO, completing the self-assessment tool annually is one component of the quality assurance program, and peer assessment is the other. All general and academic registrants must submit their SAT annually by the January 31st deadline. At the same time, 200 registrants are randomly selected annually to participate in either a peer assessment or an evidence review.
What we'll be talking about today is covered in the peer assessment guides, and we wanted to draw your attention to these on the QA section of the website. So if you go to CASLPO.com, hover over the word registrants at the top, partway down the middle, you'll see quality assurance program. There's a page for the self-assessment tool and a page for the peer assessment program. So lower on the page, this is where you'll find all the documents. We have the clinical peer assessment guide, the non-clinical peer assessment guide, the clinical reasoning tool, and the guide for the clinical reasoning tool, as well as a page on information for employers. These are all available in English and French. We also have an evidence review guide. That's not for you. And hopefully what Caitlin has explained will really help to answer the question, why does CASLPO make us do peer assessments? Again, peer assessments are not a CASLPO decision, but are legislated by the Regulated Health Professions Act. All 26 health colleges do some form of peer assessments. So your doctor, your dentist, dental hygienist, massage therapist, occupational therapist, the list goes on. Everybody has quality assurance and peer assessments. And peer assessments are important because they can support registrants' improved practice by providing education and resources, and assist the registrant to improve their skills so they can provide safe, effective, ethical care when needed. The peer assessors all have been peer assessed themselves and understand your experience and what you're feeling now. They then went on to become peer assessors. They go through annual training and take on a number of peer assessments over the year. They are warm, kind registrants who want to give back to the professions and like meeting people. They love hearing about what you do in your role. Peer assessors and this process are not out to get anybody. The process is not punitive. It can be a very positive learning experience, and registrants really enjoy talking about their role, their challenges, their successes. It's a conversation about you and your practice. So let's look at what exactly happens for the peer assessment from the beginning to the end. We have our timeline here for peer assessments, but let's go through each of the stages on their own, and then we'll come back to this slide to talk about it in more detail. So what happens before your peer assessment? As Caitlin has said, all general and academic registrants complete the self-assessment tool by the end of January. Please do submit your SAT by January 31st. I don't think we need to go through the SAT today because it should be pretty familiar to you. Looking at the practice description page specifically, you want to make sure that it reflects your role. We use it for matching, which Caitlin will talk about shortly. Section 8 has a place for the description of your practice, where it says provide additional details of your practice. And section 9 asks about timing, and you can say when you would prefer the peer assessment to take place, whether it's in the spring, the summer, early or late fall. Please keep your email up to date. Your email address is really important because this is how the peer assessor will get in touch with you. For example, if you go on leave from work, the peer assessor needs to be able to contact you. In fact, if you're going on leave, you might want to let the college know as well. The evidence is something that's submitted and uploaded to your 2026 self-assessment tool. Again, submit that SAT by January 31st because you have until March 7th to upload the evidence. And so you don't want to wait till that time. The records need to be a minimum of 5 patients. So you'll have your 5 patient records that you'll use for different indicators. You don't need to use all 5 patients for every indicator. Most of the indicators need one piece of evidence. And you're going to hear us say that a lot today too. We really want you to use your professional judgment to figure out one piece of evidence. Non-clinical peer assessments, obviously, there's not going to be any evidence from patient records. But for the clinical peer assessments, it's really important that you show what you're doing across different patients. If you work in 2 or more places, you can have evidence from both of them. So you might have evidence from the knowledgeable consent from one practice and informed consent for another. Evidence can be up to 3 years old, although newer evidence is definitely preferred. There's an article called Tips from Peer Assessors that is attached to this webinar as a handout, and you can also find it in the Express February 2020 issue. And there's lots of good advice that you can read in there before you upload evidence. So let's take a look at the self-assessment tool. So when you go to professional standards, you may or may not have noticed this before, that there's a box here that says required for peer assessment, upload evidence, and a comment box as well. When you upload your evidence, you just want to hit the save button. You don't have to resubmit your SAT. For clinical registrants, evidence from patient records is key. Please don't submit blank forms like case screenings or consent. And the guide will tell you which indicators need evidence from patient records. We encourage you to pay attention to this. For the virtual interview, the evidence uploaded is important because it will help guide the conversation. We want to encourage you to use these comment boxes. Why did you upload this evidence? What does it mean? If you upload a policy, maybe explain how you apply the policy. Let's take a look now at the peer assessment guide. So this is the clinical peer assessment guide. It's really important to go through the appendix. It is on page 18 of the clinical guide and page 15 of the non-clinical. And it explains what exactly it is that you need to upload. So for instance, for clinical, it says 1.1, 1.2, 1.3. These all need to be from the patient record. So not a policy, but actually what you do, how you do your job. As I said, you need one piece of evidence for the indicators except for 2. 1.3 for audiologists, which is I perform and document the controlled act of prescribing a hearing aid for a hearing impaired person according to practice standards and the position of the college. This indicator needs evidence from 2 patient records for all 4 phases of hearing aid prescription. So those would be the hearing assessment, the hearing aid prescription, verification, and validation. So there should be 8 pieces of evidence for 1.3. For speech pathologists and audiologists, 1.5, I'm accountable for support personnel providing intervention under my direction. That needs 2 examples of evidence. Those could be, they should be rather, different aspects of supervision, like co-signing records, consent, or a note in your calendar. For non-clinical, it's 1 piece of evidence for all the indicators, and of course, there's nothing from patient records. You don't need to upload the entire record, 1 piece of evidence except for those 2 indicators. There are 30 indicators. Pick the best piece of evidence that reflects how you meet the standards. Peer assessors will see what your records look like since there's 20 where they'll see patient records overall. I'm going to say it one more time. Pick 1 piece of evidence. This is easier for the peer assessor and it's easier for you. You must have so much good stuff to choose, but pick 1. If it doesn't show the peer assessor that you're meeting the standard, they'll let you know. We often have people say, well, for 1.2, I maintain records in a reasonable time. I don't know if I should upload, I don't know which one to do. Maybe I'll upload an assessment report, and I'll upload a session note, and I'll upload a late entry session note. One. Pick one. Pick the one that best demonstrates your record keeping. We understand that you're working really hard at your jobs, and this is not intended to be a make work project. You can check the clinical guide for which evidence needs to be from patient records and which don't. If your upload references another document, you may want to upload that one as well, but only if you really think that it helps. So what we suggest is, we're not going to show you how to actually take the screenshots. This is in the guide, or you can talk to an IT or a techie person that you may know. But we recommend having a folder on your desktop that you can save your evidence. You can send yourself the evidence via email or text, if it's a screenshot or a picture of a paper document, and then securely delete the evidence from your phone. If you don't know how to do this, you can get some IT support on it. If you're taking screenshots, you want to be careful not to upload the evidence upside down, and check the evidence before uploading. And you can see page 10 in the guides for more details. By saving it to your desktop, you can look at the evidence before you upload it, and you can also rename it. So you might want to label it so you know which indicating you're planning to put it towards, and also just so that you remember what it is, or the peer assessor knows what they're about to look like. So for this one, I have on here John S. validation of hearing aid for 1.3, but maybe it would be better to say PR1, 1.3, and just keep it at validation. And if you have already started uploading evidence and you haven't renamed it, not a problem. That's absolutely fine. It's just one thing that that might be more helpful. When you're renaming, it's really important that you use letters and numbers only, no special characters like quotation marks, because the SAT program doesn't really like those. So we can look also at some evidence. So for instance, here is an example of evidence for 4.3, which is I communicate respectfully and collaboratively with patients, relevant others, registrants of my profession, other professions, and or coworkers and employees. So we really recommend that you put the whole page in. So instead of taking the page and then blocking out everything that's not what you want it to see, let's let the peer assessor see everything that's there. So for 4.3, Fitz the cat, the speech pathologist, highlighted that the note from September 9th is the important one for collaboration, because that's when I spoke with the patient's occupational therapist. Maybe we'll go back to the SAT right now. So looking at the SAT, you can see that there is guidance under some of the indicators when there's important documents that might help. And we also have examples of things that you might want to upload. These are not things you have to upload. These are just things to get the idea going. There are some that could be live or recorded photos or videos that would be helpful for the indicators, and it says that in the appendix in the guide, for instance, 1.7 on health and safety. You can upload evidence. In fact, you should upload evidence, but you can also do it live. So some people might take a picture, and then if they have a laptop or a tablet, actually walk around the clinic with the peer assessor during the interview to say, this is where the hand washing station is. But you can do it however you prefer. A note on redacting, which I mentioned before, there's no need to redact personal health information. The Regulated Health Professions Act supersedes the Personal Health Information Protection Act. However, if you want to, you can. We may hear from hospitals that have concerns about uploading personal health information. If you or your employers have concerns, have them contact us, or you can contact us. We do have that handout on the peer assessment page with information for employers. And we also have a letter from the company that runs the self-assessment tool with all of this IT jargon about how secure the system is that we're happy to share. There is no harm in sharing with a privacy officer or with your employer about needing access to files. Again, all regulated health professionals have peer assessments, so hospitals and larger organizations will be familiar with this. It's important to note that you do not need patient consent. You can use patient files for QA, and there's no knowledgeable consent needed. The SAT is an extremely secure platform. There's no need to redact, but you can. And we say there's no need to redact because we're not trying to make work for you. This is not an arts and crafts project where you're crossing things out. So let's go through together how to upload something. So I have something ready. Again, there's some guidance here for 4.2. There's examples. Let's upload evidence for 4.2. I communicate in a manner that is responsive to the unique background, identity, and experiences of the patient, relevant others, and other professionals. So in order to upload, you click on Required for Peer Assessment, Upload Your Evidence. This box will come up, choose File, and you'll go to the folder where you keep all of your evidence. Here I have it labeled here, 4.2, open, you can see it appears, and then you click on Upload Files. Again, really recommending using a brief description of why you chose this evidence. Please don't write an essay. It's really just a short thing to remind you or let your peer assessor know. It can add a lot of information for them. So maybe here I would write, this is a handout I made for a 6-year-old and their family who speak Urdu. The visuals are in English and Urdu. Oh, maybe I'll say visuals and pictures so that I know what it is and that the peer assessor will have an idea also and why this is important, as opposed to just suddenly seeing a document in Urdu. Once you're done and you're ready, you go to the top or bottom of the page and hit save. You can do one thing at a time. You can do lots at once. Really doesn't matter. Now, let's say it's before March 7th and I actually have evidence that I think is better, or oops, by accident, instead of uploading 4.2, I uploaded my 4.1 evidence. There is a little red stop sign to the left. If you click on that, you'll get the question, are you sure you want to delete this? You say okay, and it disappears and you can upload something else. If your evidence does not demonstrate meeting the standard, your peer assessor may ask you to upload more evidence. And this is not something to worry about, but think about something else. The advice that we have from peer assessors are spend more time on the comments than on the uploads. Another tip for uploading and choosing evidence would be if you're uploading email, instead of reproducing the email in a Word document, it would be better to have a PDF of the email. Let's let the peer assessor see what actually happens in practice.
Okay, so if we're thinking about this process chronologically, you would submit your SAT as normal by the January 31st deadline. Then you would go back and upload all your evidence by the March 7th deadline. That's what Dana just demonstrated. Now what will happen is you will be matched with a peer assessor in late March or early April. Staff matches registrants and peer assessors according to your profession, your area of practice, and what language you speak, which is again why it's important to accurately complete the practice description section in your SAT. It's also important that your listing on the public register is up to date, which you can do at any time through the registered portal. That's what you use at renewal in the fall, not the SAT. For unique roles, we do our best to match you with somebody appropriate. You'll be given the name of your peer assessor and a link to their entry in the public register. You can have one veto of a peer assessor. If you choose to use your veto, notify CASLPO staff within 1 week of receiving the email, and a different peer assessor will be assigned. You don't need to provide a reason for using a veto, and the choice to do so will remain confidential. Your peer assessor will contact you to outline the process and to schedule a time for the virtual interview component of the peer assessment. If you don't hear from your peer assessor by the end of April, please let us know. Be sure to check your junk folder just in case it was filtered there. The email from the peer assessor will come from their own personal email address, not from a CASLPO email domain. It's essential to keep both the peer assessor and the college up to date with any changes in your contact information as well. So the peer assessor will contact you to schedule a mutually convenient date for your virtual interview. Contact your peer assessor if you need to reschedule, although try not to change the date too much, as your peer assessor is also scheduling around work and other commitments. The peer assessors understand how you're feeling as they will assess themselves. They will likewise do their best not to change your meeting once it's booked. The peer assessor will let the college know your virtual interview date or any changes, so you don't need to communicate that to us. The virtual interview for clinical assessments takes approximately 3 hours, but we recommend booking 3 to 4 just to make sure that you're not rushed. You and your peer assessor will choose the virtual platform for the interview, which should of course be one that you can both access. As Dana mentioned earlier, you may want to hold the interview from your workplace. This way you can show the peer assessor in real virtual time things like measures for maintaining patient confidentiality, infection prevention and control measures, or whatever the case may be. So now what happens during the virtual interview? After you've uploaded evidence, you've been assigned your peer assessor, they've contacted you and arranged the date and the details for that. The virtual interview is a conversation about your practice. We recommend having the records available from which you submitted your evidence so you can refer to them during the interview. As Dana said, the peer assessor may ask for different or additional evidence before the interview, but don't be alarmed if that happens. The peer assessor will discuss your evidence for the indicators and ask behavior-based questions related to some of the indicators. So the behavior-based questions are based on risk of harm to patients to determine how registrants behave in a given situation. There's detailed information on behavior-based questions in the body of the guide. It's page 11 in the non-clinical guide and page 13 in the clinical guide and in the appendix. Behavior-based questions are asked in all peer assessments, regardless of the evidence that was submitted. So the next section of the interview is a review of your learning goals and continuous learning activity credits from 2025. So again, as part of your routine process for submitting your SAT in January, you will have added your CLACs to your 2025 SAT already. For the virtual interview, it's good to upload evidence of your CLACs. So for example, a certificate of completion for a course. It's important to indicate your progress towards meeting the goal and the impact on your practice in the SAT. There's no right or wrong answer for rating the impact on your practice. It's your learning. It could be learning something new or validating a body of knowledge that you already had that's relevant to your practice. If you have CLACs for 2026 already, you can of course add them. The learning activity summary box is where you can provide additional details about the learning activity. And again, if you have evidence, definitely upload it. The next component of the interview is the discussion of the required documents. So for indicator 5.1, I'm knowledgeable about CASLPO standards. You'll discuss 2 documents with the peer assessor. The first is one of the 3 required documents that are listed as required reading in the SAT. Because there were several new and revised standards this year, there were a few required readings. You will just choose one of these to discuss with your peer assessor. It's at your discretion. You then select the second document from all CASLPO standards and documents to discuss. Let your peer assessor know ahead of time and choose something that's relevant to your practice. So for example, for Dana, having worked in private practice, the advertising standard would have applied, but that wouldn't have been relevant for me in clinical practice. And the last component, and again, these may not take place in this exact order during the interview. Your peer assessor can go about it in a way that they think makes sense. These will just be the components. The last part is the clinical reasoning tool, which started approximately 10 years ago based on feedback from registrants that they wished they could have engaged in a more fulsome discussion of their patients. It's only used in clinical peer assessments. It's a method of evaluating clinical reasoning through guided conversations. It consists of a set of discussion questions designed to reveal the clinical reasoning you've applied to specific cases and to promote reflective practice. The clinical reasoning tool and the guide are both available on the peer assessment webpage. If you're interested, there are also 2 mentor training modules related to the clinical reasoning tool, and they're available to view on the mentorship page of CASLPO's website. The clinical reasoning tool will be applied to 2 patient records. You will have 5 records available with different presentations. So for audiology, for example, this could be hearing assessments, cerumen management, tinnitus, cochlear implants, etc. For speech language pathologists, this could be a patient with a language impairment, a speech impairment, swallowing, motor speech, etc. Two files will be used based on your brief description to the peer assessor. You select one and the peer assessor will select the other based on your description. The clinical reasoning part of the interview is audio recorded. This allows the peer assessor to be completely engaged with you in the discussion and to write notes and review them later. Again, it's a good idea to have these patient records with you for you to refer to them and help you remember details.
Okay, so now that we've talked about what happens all the way up to including the actual peer assessment itself, we can have our first break for questions, and I see lots of them coming in. I will say that we might, actually, we will probably only take one or two because we will have time for more questions later on.
So there's a question, does the evidence from patient files need to come from the same 5 files that will be used during the clinic? So I think it's whether the patient files for clinical reasoning need to be the same as the 5 files that you use for the evidence upload. And the answer is it's up to you. It can be the same 5, different 5, a mix of the two. It's up to you to choose. You don't need to have 5 distinct files for the clinical reasoning.
For sure, and I'll take a question. For non-clinical peer assessments, do we complete the clinical reasoning tool, or is it only for clinical? Well, it's only for clinical is the short answer, but if you think about it, if you're in a non-clinical role, you yourself won't have patient records. You might in that once in a very, very blue moon, you have to go in and step in, or you might say, well, the SLPs or audiologists that are working on my team, I could show what they do to show that they're meeting the policies and procedures that I've set up. But really, the clinical reasoning and the patient files are for those that are actually maintaining the patient files and seeing patients. Okay, Caitlin, I'm going to say let's move on, and then we'll save time at the end for questions.
Perfect.
So let's talk about what happens after the peer assessment. At the end of the peer assessment, your peer assessor cannot tell you if you were successful. That's determined by the Quality Assurance Committee. You should know how you were doing based on the conversation and if there was any remediation.
If the peer assessor finds that you need work to meet 1 or 2 of the professional standards and indicators, they'll discuss the indicator with you and provide virtual remediation. This happens occasionally, and it's nothing to be concerned about. You'll likely have a sense whether this is indicated during the interview. In the moment, education and remediation is the most effective catalyst for change in knowledge, behavior, and activities. You will generate a solution and agree on the evidence required to show you're meeting the standard with the peer assessor. This is self-directed learning, so you'll be responsible for setting a learning goal and achieving appropriate continuous learning activity credits towards it. You'll agree on a date within a short time frame, which is 1 to 4 weeks, by which you can upload the new evidence. The peer assessor will summarize the remediation plan to you in an email and copy Dana. When you have provided evidence of meeting the standard, the peer assessor will then submit their summary to the college. If you need work to meet more than 2 indicators, the indicator poses a significant risk of patient harm, something like confidentiality or prescribing a hearing aid, or you're unable to generate or enact a solution, the peer assessor will write a report, which you will have the opportunity to review before it goes to the Quality Assurance Committee, who will determine next steps. These are some common SAT indicators that have needed virtual remediation in the past. We're just drawing your attention to them for your reference. We did want to highlight the indicators related to record keeping, both informed and knowledgeable consent, and supervision of support personnel, as they're consistently identified as needing remediation. We want to reiterate that if a knowledge gap is identified, the objective is to then make sure that you understand and are meeting the standard in practice. Remediation is about learning, it's not about penalizing clinicians. There are strict confidentiality provisions in quality assurance that prevent communication with professional conduct except in extreme cases. The ultimate objective is to confirm minimum standards are being met to ensure that patients are receiving quality care, not to find issues or to get people in trouble. You can kind of conceptualize quality assurance as preventative medicine. It's addressing things before an issue happens, as opposed to reactionary, which is having to go back and address something once there's already been an issue happen.
There will be a lot of documentation after the peer assessment. The peer assessor will complete a document within 10 working days, and we will let you know if there's been a delay. It could be a summary. A summary is very short, and it means that you have met or exceeded all expectations. The summary does not reflect all of your work. The peer assessor will also write a summary if there is virtual remediation that has been completed to the peer assessor's satisfaction. A report, on the other hand, shows which indicators still need work. This might happen if there are many indicators not met, or it's a high-risk indicator that requires more than virtual remediation, or if the remediation was unsuccessful, and the Quality Assurance Committee will direct you on how to proceed. In both cases, you are sent a copy of the summary or the report, and you have 30 days to provide a response to the committee. The summary or the report will be forwarded to the Quality Assurance Committee as soon as your response has been received for their next meeting. If you have no changes or no problems with it, we suggest replying right away. Waiting the full 50 days to respond will prolong the process for you because it'll take longer to get to the committee. It doesn't have to be a fancy email. We got some this year that said, looks good, thanks, but just something to let us know that you have read it and are ready for it to move on to the committee. The report, the summary, and any information you send are anonymized. The Quality Assurance Committee will review your anonymized report and summary, and they'll decide if they need more evidence or if you demonstrate the required knowledge, skill, and judgment. The committee meets about every 6 to 8 weeks, and you'll receive an email letting you know their final decision, hopefully congratulating you for completing the process. When you get this email from the Quality Assurance Committee, you know the process is complete. If you like, after receiving this email, you can remove your evidence from your SAT using that little red stop sign. Once this is finished, you are not eligible for peer assessment or evidence review for 10 years. You'll also get a link to a survey from the Quality Assurance team in this email. You may feel like you're doing these all the time, but the feedback has been invaluable and informs future peer assessments. How could we go through the process better if we don't hear from you? And a note on the anonymized, I see a question come up on the anonymized number. Nobody in the committee knows that it is Dana Prucci that they are reading the report or the summary for. It will say PA and then a number. The number might even be in your emails now, for instance, PA 30026, which would mean your person, I guess, 300 for 2026. And that's all the information that they will have. While there's a timeline on this in the guide, and it's really important, it has lots and lots of details for you at the back, we wanted to go through this slide again. So in January, you were informed you were selected for peer assessments, and maybe you've started collecting evidence. Please complete and submit your SAT by January 31st. And you will also be participating in the webinar like today. In February, continue to collect and upload your evidence. You do not need to resubmit the SAT. Once it's submitted, that's done. You just hit save. In March, you ensure that all your evidence is uploaded and complete. You can use the checklists. And you'll also be thinking about the second document that you'll want to discuss, as well as the first document this year, since there are lots of choices. In April, you'll be notified who your peer assessor is. You can request a new peer assessor if you choose. You and your peer assessor will schedule the virtual interview and decide on which platform you'll want to use for it. And you'll tell the peer assessor the documents that you want to discuss. From May onwards, you'll have your peer assessment. You'll decide on potential records for the clinical reasoning tool, and it's best to have them available during the interview and have evidence records available if possible. You can review your goals and add others if you choose, and add your earned plaques, and maybe reread the required and selected documents. So let's look one more time at some of the resources that we have available before we go to our last question period. We also wanted to remind you that peer assessment is about protecting the public. It's not that the college thinks you're bad at doing your jobs. In fact, we know that most of you are amazing. But this is the way that we can show it to the public and protect the public. If I could say one thing again, I don't know how many times I've said it today, one piece of evidence aside from those 2 indicators that require more, use your best professional judgment for what that evidence will be. If you're feeling, let's say, concerned, you can reach out to us and we can connect you with someone who has been through a peer assessment in the past. And remember that this is your opportunity to demonstrate how you practice. So while you may ask friends and coworkers, what have you uploaded in the past? What do you think I should do? Think about what represents you as an audiologist or speech pathologist in your practice. If there is an area that needs help to meet the standards, that's okay. That's why we're here, so that we can help to protect the public and help you to improve and protect the public in all of your work to meet those standards.
So these are some final key takeaways that we wanted to leave you with before we end on some registrant feedback about the peer assessment process. The first is to help understand the peer assessment process. We've created the guides as a resource for registrants to refer to. They're there to help. We encourage you to take time to read the guide, to understand what you need to do and by when. The guide should be your first stop if you have questions, and reference that first. The next tip is to spend time being critical about what evidence to upload, but not too much time. Pick what best demonstrates that you're meeting the standards. Again, we would advise against uploading multiple pieces of evidence per indicator. Sometimes more isn't better, it's just more. It makes more work for you and more work for the peer assessor and can actually make it less clear to the peer assessor how you're meeting the standards. It makes it harder to identify amongst more information. Make use of the comments to explain your evidence. This is your opportunity to explain to the peer assessor how this evidence shows that you're meeting the standard and to add any context if it's needed. So for example, about how your workplace specific policy applies in practice. Leverage the resources built into the SAT, including the guidance and examples of evidence in the drop-down menu beside each indicator that Dana demonstrated earlier. They're there to help you and give you some ideas. If you need clarification on anything, you can contact Dana or me and we're available and happy to help you. But we did want to take this chance to explain the limits of the support that we can offer to manage expectations. So we often get feedback on the survey annually that, oh, well, I wish that Dana or Caitlin had given a specific example of evidence for this indicator or explained more what this indicator is or what it's getting at. We won't be able to tell you what evidence to upload or whether the evidence you have chosen is good or not for a couple of reasons. So first, Dana and I as staff members versus board or statutory committee members don't have legal decision-making authority per the RHPA, so we can't say whether something is acceptable. And second, that would undermine the integrity and fundamental purpose of peer assessment. Ultimately, demonstrating how you're meeting these minimum standards in practice is your responsibility as a self-regulated health professional. This is about your practice and how you're meeting the standards. If we respond to a question with use your best clinical judgment, we certainly aren't trying to be intentionally unhelpful. It's that the question has maybe gone outside the parameters of what we're able to help with and is now in the domain of something you'll have to decide. Again, you'll be able to talk through the peer assessor and explain the process. We would like to reiterate, this is not a punitive process. We start from the assumption that everybody is meeting these standards. It's more spot checking and again, preventative medicine. Lastly, be responsive when your peer assessor communicates with you and make sure that you meet all applicable deadlines. If they ask you to upload new or different evidence, let them know when it's ready for them to review. These are easy things to do to help the process go smoothly and are entirely within your control.
We wanted to share some of the feedback that we get from the survey. And so these are comments from 2025. Really, these are general themes. So we thought that these would be pretty representative. So one said, I'd always felt apprehensive about this process, but the peer assessor created an environment that felt more like a constructive clinical discussion. And we actually get that a lot about that it's a clinical discussion with a peer, and that's why it's called peer assessments. Overall, it was a positive experience that reaffirmed I'm on the right track in my clinical practice. We have new peer assessors in 2026. These are people that successfully completed their peer assessments and will not be chosen for peer assessment themselves while they're peer assessors. There's lots of training available for this process, and there's also information on this in a previous Express newsletter issue. It was from 2022. Okay, so that is the end of our formal part of the presentation, and now we have some time that we can look at questions. I don't know if you've been able to monitor more of them while we were talking, Caitlin. I think I need
Yeah, there's one here. Can you clarify what we are required to do as an SO? This is a question generally about not applicable indicators. So what are we supposed to do for 1.3, which is about prescribing hearing aids as an SLP? If something is literally not applicable, which prescribing hearing aids should be for SLPs, you would say not applicable and you wouldn't upload evidence for it. It's, as I said before, in my previous clinical roles, advertising was legitimately not applicable, and therefore I don't have any evidence to upload for that, and you wouldn't upload evidence.
I would say another example for speech pathologists would be 1.3, prescribing a hearing aid. Speech pathologists, you should not be prescribing hearing aids. That should absolutely be non-applicable. So there's no evidence for you to upload. If you're in, audiologists and speech pathologists tend to do some very interesting roles, or not tend, but many of us do. And so if that's the case, that you are in one of those sort of atypical roles, and so you might say something's applicable, but you don't have evidence. First of all, be creative, try to find some evidence, but use the comment box and explain why you said something's applicable, or why, and you need it, or why something is not applicable. And you and the peer assessor can always have a conversation about it.
There's an interesting question from somebody else that's a nice segue from the last question. Are we required to show evidence from both places of work or just our main full-time place? I supervise a CDA through one of my employers, but not in the other. So you are not required to upload evidence from both workplaces for every indicator. However, if one indicator is in play at one workplace but not the other, then it is applicable, and that's part of your practice, and you should upload evidence for that. If you do it in one place, then it will apply for the peer assessment process. Hopefully that answers your question.
Anything that you're answering, I meet the standard, or I need work to meet the standard, you should have evidence for, really. And I think it's important to show things from both practices, because it's showing how you work. That maybe, thinking about my private practice, I didn't have forms for consent, but I had a conversation. So it would have been really easy for me to upload the consent forms from where I worked in the public. But I think it would also be nice to show this is how I do it in my private practice. I wouldn't want to upload both of them, because that's more than one piece of evidence, but maybe one for informed consent and one for knowledgeable consent. There is a question here on, for the clinical reasoning tool. I only see patients with one problem. What do I do? So we know this happens, that audiologists might only see people with cochlear implants, or a speech pathologist might only see people with motor speech or swallowing. And while it is one clinical problem, we want to think about how every patient is different. And so there will be things that are different. Maybe someone speaks a different language and you needed an interpreter. Maybe there is something about who they live with. But think about what those varieties are that are in your practice, even though it's all the same kind of problem. Not every patient that has a swallowing problem will actually have the same problem.
Okay, we have another question asking approximately how long it should take to gather and upload evidence. So we can't give you a concrete number for this, because it depends on a variety of factors, whether you're working part-time or full-time, how many patients you typically have on your caseload, your workplace, and the infrastructure that's there, a whole host of things. But essentially, it should take long enough for you to get the desired result and that you're taking it seriously, but not longer than that. So put in enough time that you feel confident that you understand the standards, and that your evidence reflects that you're meeting them in practice. But as I said to Dana in conversation, the law of diminishing returns really applies here, and any additional effort that you put in beyond this won't yield any added benefit, and we would say isn't worth it. It's not the intention that you spend hours and hours agonizing over this. Another point about redacting personal health information. It's not required by us, so if it's not a requirement by your workplace, that would be something that you shouldn't spend time on. It's a lot of extra work and it's not necessary, so therefore it's probably not worth putting time into. Another note on redaction, sometimes if you redact too much, it then doesn't demonstrate anything anymore. And it also is then hard to see whether the minimum requirements are being met for the indicator.
Yes, that's very true. And I don't remember if I said it, but if you're going to redact, say, a patient's name, great. Patient's address, absolutely. Date of birth could be really important. And periodically we get calls from the peer assessor saying, I don't even know what I'm looking at because everything's been redacted. That's not so helpful. But as Caitlin said, you want to take time to think about this. Don't just sort of grab the first things that you see. But if you're taking days and hours, and if you're losing sleep over this, you're doing it wrong. If I could say that.
So we have another question. You mentioned the peer assessor is chosen based on where we are located. Is this to avoid conflicts of interest? That's part of the concept of the veto, is that you're able to say, if you have somebody who, we wouldn't know this, but if you happen to have conflict of interest with, you can veto them. It's more that we try and match peer assessors to you, so you have a real true peer, that it's somebody who is knowledgeable about your area of practice, works in comparable areas, is able to understand and appreciate your evidence and your practice. That's more the nature of the matching.
Exactly. There are a bunch of questions. We all have this theme about the recency of the evidence. So we say the past 3 years, but that can include 2026. So because you have until March 7th to upload, if you are seeing a patient or something comes up in January or February, great, that could be wonderful evidence. That certainly is recent. It can be from the last 3 years, but just think about you as a clinician, the way that you're practicing now might be different from what you did 3 years ago. And so more recent is better, as I said. You know, it's a problem, say, if we get evidence from 10 years ago, there are some things that you might be doing the same, like the way that you get consent, but I would certainly hope that you have changed as an audiologist or speech pathologist and how things get done.
Well, there's a couple questions about the process for selecting your records for the clinical reasoning tool. So someone's asked, do we choose 5 full files for the clinical reasoning tool discussion as opposed to individual pieces of evidence? So yeah, you would choose 5 patients that you can have a fulsome discussion. There's no need to upload full patient records into the SAT, nor should you. You just have them available to present to the peer assessor. So you would say, have 5 patients, say, this is this patient, they have this profile, very briefly present each 5, you pick one, they pick the other one. You don't need to upload anything, and you don't need evidence. It's a discussion.
Yeah, absolutely. If you have electronic medical records and it makes sense, then you could always share your screen during the peer assessment to show something in the record to the peer assessor. One of the reasons we say to have the records with you, I'm looking down because I have my old files here. When I was doing the clinical reasoning tool, and you know, this was a child that I had seen weekly, I knew everything back and forth, and the peer assessor asked me a question, and I thought, I actually don't remember why I chose that assessment, or I don't remember. So having the file, I could flip through and say, oh, right, it's because ... It's that memory recall to have the file with you. It's not necessary, but you absolutely do not need to upload anything. As Caitlin said, clinical reasoning tool is about the conversation.
Yeah, it's the concept of chart stimulated recall that is used across health professionals. That's the kind of rationale for the clinical reasoning tool. So you see me looking over here just at my other screen to make sure that we haven't missed anything that anybody's asked. And I don't think we have.
No, I think everything else we seemed to cover. Sorry, it's probably not so fun watching us read questions. But okay, let's see if there's anything else we wanted to get to. As far as reaching out to your peer assessor, you should hear from them first. Once they're matched with you, they will have your email address. You probably won't have theirs. Which is why we ask you to reach out to us. If you don't hear from them by the end of April, maybe the email got lost, something happened, but it's always good for us to know so that we can help as needed. If you have questions, you can reach out to us. Once the peer assessor has emailed you so that you can plan a time and just basically say, hello, this is who I am, you can email them as well. But just remember, just like you're very busy in your job, they have their jobs as well. So we don't want to we don't want to spend too much time before the peer assessment asking them questions. They might direct you to us, and that's okay. So I think that takes us to everything. Again, if you have other questions, feel free to reach out to us. We're happy to answer as we can. But we wanted to thank you for joining us today and wish everybody best of luck.
Thanks, everybody.